really sensitive as well, but I actually think that all of those are together, because I think the pharmacist in those, you have pharmacists working in your, in all of your technology. So that pharmacist is on the team as well. So however we do it best, whether we had health coaches, pharmacists, all of them using our apps with the patients, and we got people to goal for blood pressure in 17 days. So it was a much better than usual care situation in very difficult cardiology patients, not primary care. So I would agree with you.
Great. Final comment here. Microphone's right there.
Thank you. I'm Joan Warblin, and I'm a volunteer, and I'm chair of the board of the California Chronic Care Collaborative. Two observations I made. Number one, I was part of the national study that the American Pharmacist Association did on diabetes. I'm a diabetes nurse expert. That's my career. And I was in Southern California, out in the middle of nowhere, for my first year of retirement from the university, with 400 migrant laborers. And one of the values, I had a pharmacist with me. We sort of saved each other's life. But what I did learn from him was that particularly in the Sacramento area where we are in the valley, we have a diverse migrant population. We have refugees. So we have many, many cultures. And the one common thread that I have found has been the pharmacist, because in so many of these countries, there are no physicians, there are no hospitals where these people are coming from. But there seems to be a local pharmacist where you can get your antibiotics and things. And what I found was, in doing our histories, we learned so much more through the pharmacist because it was non-threatening, and they saw them as a friend and maybe, reminiscent of home, of better times. So I think it's invaluable, and I do work with the schools of pharmacy in the Sacramento area. So I think that's it, and I think you have to go where the patient is. Unfortunately, many of these programs that are so wonderful never get transported outside, and that's what we as a community, I think, need to look at now, is to get this health care, particularly chronic diseases, outside of the local area where the real people are that have to deal with it. It takes a lot of support.
Thank you so much for sharing your experiences all. We're going to go on to the next vote, which is this idea of optimal diabetes care. You saw many measures today in the intermediate outcomes area, and one thing that HealthPartners had adopted is this optimal diabetes care metric, which is a bundled measure. And so achieving optimal care is challenging. Does your organization measure and provide feedback on optimal care for diabetes as described by HealthPartners? So this would be the multiple measure, composite measure that was much lower, around 50% or so.
Mm-hmm. Yep.
So it's definitely a higher bar to meet. So we're seeing how normalized the optimal diabetes care measurement is here in the audience. Great, we'll cut it off here. So about half and half of you are doing this. So I guess one of the things that I was wondering about for those of you who used it is, one of the things is you kind of want to win, as Jerry likes to win here, but you got to celebrate your successes for additional energy to keep on with the initiative. And I had wondered, through bundling of these measures, it's sort of harder to move these things. And so I was wondering the motivations behind embracing this measure and what has been your experiences of using the measure?
Yeah, thanks. Well, I think one of the benefits of bundling is it's a patient-centric view, if you will. So if I have diabetes, in order for me to optimally manage and prevent cardiovascular disease, I should be doing all of these. I do think it drives up the individual components more so than if you did them separately. So if we look underneath that, you would see blood pressure control near 85%, 100% aspirin, lipids are around the mid-90s, A1Cs mid-70s. So that's always been the challenge, if you will, because there's a lot more involved in that. But I do think by having it be all or none, it lifts everything up. And it's a nice way to engage a patient, and these are all the things to do to optimally manage your chronic condition to prevent you from having these things, or to help preserve some of the cultures we work with. It's about having the conversation around preservation and not the fear of loss.
Thank you. Others in the audience, with respect to those who haven't embraced the optimal care diabetes, is it something that's tough to do because of data reasons, or scary because of backlash, or tough to monitor? Is this appealing to those of you who don't do it yet? So I see some yeses here. Great. So we'll move on to the next question. So this is long, and I'm just going to get to the second part of this. But as we've seen, these big systems can afford to have either embedded pharmacists on a rotating basis or dedicated to particular practices. But smaller practices will struggle with implementing these embedded pharmacist models. And so wanted for you to vote, how would smaller practices who couldn't afford to incorporate even an embedded pharmacist a day a week, how would they go about providing the expertise of pharmacists to their diabetic patients? So there's three options. The first one is telephone or video visits with pharmacists supporting multiple practice sites. B would be work with local commercial pharmacies to collaboratively manage medication management services. This would be the Ralphs, the Walgreens, CVS's, and partnering with pharmacists in the communities where these small practices are. And other would be mixed bag, I have another idea, etc. Great. I am not getting movement on this clicker. Great. So it seems like another 50-50 here. There's no convergence. But it seems like these are both viable options. I guess there are some other ideas. I guess from the panelists, as you think about ways to get pharmacist expertise to the patients that need it, as you were rolling out your initiative, did you think about alternative models that could reach smaller practices or maybe independent physicians in your network?
Absolutely. We felt that we needed the strength first and recognition of the pharmacists. I think if there was anybody who came today wondering if a pharmacist should be part of the care process model or the team-based care, hopefully that's cleared up, that's very pertinent and important. So the idea of a different model clearly, I think, would roll out from the model of strengthening the role of the pharmacist on the care team. Now that it's understood, it's been implemented in whatever way it is, it then gets the attention of those who have the dollar signs, the money. That's one of the biggest things, is how are you going to pay for this? This is not a billable service. And so if the pharmacist finds a way that they'll gain from this, then perhaps they will. But to come to the pharmacist in whatever model that you have up here, be it a telephone service or some other way to reach a smaller community, I think there needs to be some way to finance this. And that's one of the biggest troubles and deals, but that's what this paves the way for, is proving that there is health outcomes and health benefit from this, and then those people who are in the position to provide the services, the FTEs or whatever, are now in a position. So I do think if someone has tried these things and they haven't worked, perhaps the world is changing, and now we'll be able to find some ways to fund this. And so these are certainly appropriate ways to reach smaller populations. And I think now would be the time for someone to retry if they've tried it in the past.
Great.
Hi, I just couldn't help but say that we have modeled a telephone-based pharmacy support program. We use RNs, coaches, and dietitians as well for hypertension and diabetes, and actually working with heart failure and asthma as well. But it's been extremely successful, and our connection with the patients is extremely strong. We audit all of our calls, and I listen to them all the time. And the patients are extremely trusting, and they can answer the phone. And we mine our data looking for patients who have 3 persistently elevated blood pressures. So we know it's people who really, aren't kind of just intermittently out of control. And then we just reach out to them, have very high success rates reaching them, and very, very high success rates with patients staying engaged with us and getting their blood pressures at goal.
Thank you for sharing. Excellent. Comment in the back? And then Dr. Oravetz.
Hello, I'm a pharmacist, and I was fortunate to actually work in a home model at Sutter, Sacramento area in a primary care model. And the way my position was funded, I'm a faculty at California North State University, and I train pharmacists. So this was a pilot program, so how a small primary care practice can gain a pharmacist is employ a PharmD faculty member from a local university that's around the area, and then in turn gain their expertise while they're training their rotational students. They can actually have a pharmacist. So that's what I've done in Alhambra, Sutter Health, with the teaching model that I was there for. Thank you.
Thank you.
Thanks for sharing that model. Sounds very promising. Dr. Oravetz?
Yeah, so as I think about some of the big pharmacy health plan combinations that are coming down the line, I actually believe the biggest growth opportunity they're going to have from a revenue perspective is improving patient adherence to meds, something that we've done collectively an awful job at. Imagine if they could add 20 points to med adherence rates, how much growth that's going to provide a combined Aetna CVS or an Express Scripts. They have economic incentive to improve adherence rates, and good for us because we're going to take advantage of that. When these patients get under control, I think the Kaiser data that you saw is very compelling. When you manage chronic disease effectively over a long period of time, there's huge advantages. That the data's out. I mean, the Kaiser data is really good. So I think I'm not sure that ultimately we're going to solve this on the group side. I think this may be one of the first realized benefits of these new mega mergers coming down the line.
Thank you. So we're going to move on in the interest of time to the next provocative question. And this one's about the care team. So we've seen different models of care teams, including pharmacists, nurses, health educators, et cetera. And my question to the audience is, Healthcare Partners uses this neighborhood that has all the team members, the PCP, diabetes RN, specialists, the pharmacists, and registered dietitian. Intermountain relies really heavily on the pharmacist medication management program. My question to the audience is the full team needed to manage diabetes care? So to what extent is the full complement of the team needed, or is a more limited set of team members sufficient for some of your patients? Yes or no? So this is why probably my colleagues' study about practices that are larger being a bit more costlier bears out here. It seems the inclination is to use all. And so I think this goes back to, I'd love to ask you all in your decisions and how to architect the team in terms of the resources and your emphasis on specific members of that team.
Maybe one way of phrasing it is all the skills are needed, and whether or not you could get all the skills in one role might be a question for you, as opposed to having different roles. I think historically we had diabetes educators and dietitians embedded within the clinics before we had pharmacists, and so pharmacists came later. But between the three disciplines, they've kind of worked out and collaborate with each other under who has what, and sometimes patients need more management around diet and exercise. So maybe a different way of saying it, all the skills are needed, and there might be different ways of doing that.
Could I bring up two phrases that we think often about in our organization, and stratification was one, and identifying the appropriate patient for what skills are needed from the care team. And then the second one is workflow. Workflow is huge for us, and we're trying to become more efficient and improve workflow in such a way that we take the particular strengths of each one of the team and maximize that at the appropriate time. And so clearly if we're doing a televisit, the medical assistant is not there, but the medical assistant plays a very important role even still in so many different ways. One of the things that we've been most impressed with is our care managers as part of the team. We actually refocused our emphasis, I suppose, in Intermountain on hypertension in 2017, and our diabetes numbers started to go down. And from one email from our medical directors to the care managers that said, start working the diabetes list again, a single email, we saw a significant change, velocity in our diabetes care, that it went directly back up again with a single email to our care managers, please be part of the team again, we need you. And so each person in the team is valuable, and to realize what role they play and when they play it makes us most efficient.
So important lessons about stratification here and targeting. So our final question here for the audience is getting back to this most operationally feasible strategy. I know that OBAR, what Dr. Oravetz covered, is clearly not the top in terms of operational feasibility for most of you all. But just to get a temperature gauge here, to what extent are your patients ready for engagement in diabetes digital medicine? So using these apps and getting prescriptions for these apps to monitor blood pressure or symptoms and patient-reported measures. All right. So this is a 50-50 group. About half of you guys feel that most are ready and some are ready. But surprisingly, I think you guys are optimists in the room. There's only 4% that say few are ready. So this is changing times here, I think. Any comments about readiness? Any final comments about readiness for digital medicine? Or maybe Dr. Oravetz, if you have any additional thoughts about maybe surprises on your journey.
Well, I think, similar to what we talked about, it's really good that we have care teams, but the care teams are going to evolve. This area is going to evolve as well, right? And so I'm not here to say that we have it all solved. I think we're onto something. And we in healthcare just love to throw people at problems. That's what we do best. I challenge ourselves every day. Yes, you need people, but how do we use our resources more effectively? And stratification is a big piece of it. You got to know which patients to touch. But then how do we blend all this together into something that's, look, ultimately it's got to be more affordable, right? It's got to be more affordable for everyone. We got to get better outcomes that cost less. So I think, I don't know exactly what the end game here is, but that's the trajectory we're on.
Yeah. Great. So my final question to the panel, and then we'll open it up for audience questions to the panel, is really, in any major organizational change like you all embarked on, there's going to be resistance to change. And people are set in their ways of doing things. And so I wanted you to maybe elaborate on a bit on a specific barrier to adoption that you were able to overcome with respect to implementing your strategy. And if it's related to physician resistance, that's even better.
None of us have any experience with that. We don't know what you're talking about.
I can start. But certainly when we started standardizing our work, and it was way back when, but we were afraid to actually use the word standardize because we thought physicians would view that as cookie cutter medicine. So we had to have the conversation around, it's about standardizing process. I would say a mistake we made is we didn't spend enough time talking about the why we were doing what we were doing. So by the time it came to the physicians and the different clinics, it was more, here's what we're doing without the context. So I think one of the things is doing the context, and we all know that the pace of change in healthcare is just accelerating, and we might know the context, but how do we make sure that those that we support know the context as well? And then finding a couple of people that are willing to try. So our method of testing is generally to test it in 3 clinics, get it to a steady state, and then spread to all. And that's worked for us. We've done that probably for the last 10 years, but that's the way that we do it. And once you see the results go up from the test of change, then we generally have the clinicians host a webinar that we're involved in testing the change so that they can have a peer-to-peer conversation. So that's one of the ways we've addressed it. Have we completely solved it? No, I don't know that anyone has, but that's our approach.
Key nugget of wisdom, standardization, efficiency, these sorts of things are kind of scary. Dr. Jones, do you have anything to add here?
Communication. I think communication is a critical piece, and how you set up communication within your system is a factor worth looking at, spending some significant time on. One of the communication tools that is used in our organization is a mandatory clinical learning day for all primary care physicians, and they're offered 5 or 6 times a year. You have to sign up for one, and when you come to that, there's a communication that's had that helps people to understand, have a forum for them to ask questions, to get the whys, and we present a number of different things there, including the difficult to adopt concepts, as well as the goals. In our last clinical learning days, we used I think it's called Kahoozits. It's a method of at the end monitoring who learned what, and so they have a input from the physicians. And did you understand, what is our goal for diabetes care? What is our goal for colonoscopies? What is our goal for, and we went through and had that feedback learning to the physicians, so they all appreciated the goal and the why. And that was one tool. There's a number of ways you can communicate, but that's the way that we've chosen, along with a number of other things. And the last that I would piggyback on with Beth's comment is, once we've got a few clinics that do something well, we publish that and help people understand why they're doing well, and hope that the physicians then have that desire to be better practitioners, and that helps with the communication.
Yeah, and I would just comment first, change is incredibly hard. For anyone, for all of us, whether it's chronic disease or whether it's our clinicians. What makes it doubly hard is we have glaring deficiencies in our training. So the stuff we're talking about, none of us were trained to do. So that makes it doubly hard. I like explaining the why. You have to spend a lot of time communicating that. You better be making their lives easier. If there's more clicks involved, it ain't happening, right? So you have to make their lives more efficient. Right? They have to see that there actually is a better state. And then you just need physician leadership that just, you just can't give up. Right? We've got to get collectively to a better place. And that requires physician leadership, which is lacking on a national scale at the level that we need to really transform our healthcare system. So you just got to stick to it. And we've got to have more people out there doing it.
Great, thank you. Are there any final questions from the audience related to this panel? Yes, Hattie.
I'll never forget, and I'll just speak really loudly until I get to the microphone. In 2013, I was able to do more reading than I typically do because I had very badly broken my ankle. So I remember the July 3rd, 2013 JAMA issue that highlighted the work of HealthPartners Minnesota about adding the pharmacist to the care team. And what was so exciting about that issue was that it was that inflection point where it went from being the pharmacist saying, look, we can do a really good job at this, to the physician saying, let's take it to the bank, let's do for blood pressure what we did for banking with ATMs. And I'm just wondering, Dr. Averbeck, if you could elaborate on how you created that model, because it's really very different. It's not a face-to-face model. How did you bring the physicians along, and how did you bring the patients along? Because the data out of that is consistent with what you all showed as well. That is very speedy and impressive results for your patients in a very innovative model.
Thanks. I would say it's probably a combination of things. I mean, certainly all improvement is built through relationships. So the fact that our pharmacists have relationships with the clinicians, we have a good relationship with our research institute. And so when our research institute will do a project, we actually co-design the workflows with the researchers so that it's something that's operationally feasible. And so I think and we continue to do different studies, and so that's just been our history and our culture. I would say the interesting thing from the patient standpoint with that study is they didn't like it when the automatic blood pressure cuffs and the telemonitoring went away. And so now that we're spreading it, not outside of a research protocol, we learned that, and so now it's you get to keep the monitor. But I mean, someone alluded to that earlier on. Patients didn't like it when the technology went away as part of a grant. So I think that's something we have to figure out in future is when we do the protocols. How do we make sure that if it's something the patient's using, they get to keep it afterwards?
Can you also say anything about what happened to your cardiovascular event rates after you got
sure.
your
Yeah.
blood pressure
Yeah.
in good control?
Yeah, so earlier I showed the graph that our optimal diabetes results went up. During that same time, the cardiovascular complications, amputations, and incidence of retinopathy decreased by 50%. And so when we talk about kind of patient-centered outcomes and preservation of hearts and brains and eyes and limbs, that's the important part for our patients. But yeah, we were able to see that cut by 50%, and that's helps motivate our clinicians and our patients, and we can share that with them.
So that saved you a little bit of money cutting your event rates by 50%, right? Can you elaborate on that a little bit?
Yeah, I mean, when we did the study a few years ago, I mean, it's a significant amount of when you look at kind of the triple aim, quadruple aim, if you will. I mean, certainly we saw better health outcomes, better experience for patients, lower cost, and we continue to see, even though the whole community's gotten better, there's still a delta in cost difference between those that have optimal diabetic control compared to those that don't. And it has to do with emergency room and hospitalizations and complications.
Wonderful. Thank you so much. Excellent work.
Thank you. Any final questions? Yes.
Hi, very impressed by all presentations, all innovations, all results, outcomes. Just wanted to know, in your presentations, each of you referenced various materials, and I was wondering, I'm sure many of us would be very interested in seeing the kind of behind the scenes, the protocols, the collaborative agreements. Is any of that available via Hattie to the rest of us, or is it online, or how do you communicate that even in your organizations? Is it proprietary? That was my question. Thank you.
Yeah, I honestly don't know what my organization would say if I tried to publish that. I think they'd be a little bit reticent, but I can find out.
And I have some other slide presentations that go into more details on a lot of this, and so we, in the interest of time, condensed it, and so we'd be happy to, connect with you and share.
Great. Well, with that, that's the end of this panel. Thank you for the 3 excellent presentations and for this great conversation. I'd like to introduce now our 2 final presenters who will share their research about moving patients into A1C control. First, you'll hear from Dr. John Cuddeback, Chief Medical Informatics Officer for AMGA. Dr. Cuddeback leads AMGA's analytics arm, which brings together AMGA member organizations to improve population health through comparative clinical analytics. And lastly, you'll hear from Dr. Jim Tuttle, who is the diabetes ALL champion at Kaiser Permanente, where he has helped spread Kaiser's cardiac prevention program to community clinics nationally. He serves on the American Diabetes Association Standards of Care Committee, and he is also an active participant in the Right Care Initiative and has served on the Together to Goal National Advisory Committee. Please give a warm welcome to Dr. Tuttle and Dr. Cuddeback.
Thanks, Hector. There's nothing more reassuring if you're trying to improve the care for people with diabetes than to learn that Jim Tuttle is working on the same idea that you are. And that's the fortunate thing that happened to us here on this concept. Looking into, as Janet Wright mentioned this morning, why is it so hard to improve control at the population level? And there are a couple of reasons, and I'll just give you the results now and then show you the data. But while some people are slipping into are moving into control, and you're working pretty hard to get those people into control, others are slipping out of control. So that's one thing that's going on. We're in Virginia, so we tend to think of filling up a leaky bucket as the metaphor for this. Jim is